salmeterol, your Ceravent, and there is a black box warning on those that causes sudden death. So what we need to know about albuterol mostly is selective beta-2 agonist. It has minor beta-1 activity, where Xopenex has no beta-1 activity. So if you have a patient on digoxin and you're adding albuterol, you need to monitor those digoxin levels for the patient. The reason for that is the albuterol and the digoxin, they both battle for those receptor sites. Okay, see if this is working. Salmeterol is your selective beta-2, the long-acting, has a 12-hour half-life. And then other beta-2s. So mostly we have your precautions and your contradictions. You have your cardiac arrhythmias. Your diabetics need to watch this. It can cause some hyperglycemia. And your long-acting beta-2, it has that lovely black box warning on it. The risks of Ceravent and formoterol outweigh the benefits and should not be used singly in asthma for all ages. Twofold increase in catastrophic events, asthma-related intubations, and death. So when you see these drugs, you try not to use them. You try to use everything else that you can. There's a lot of great respiratory drugs out there. Terbutaline is a pregnancy class B, and it's actually used to stop preterm labor, so this is a drug that can be used in pregnancy. The albuterol is also able to be used for children. So your beta-2s, they can cause tachycardia, palpitations, CNS effects, tremors, dizziness, shakiness, nervousness, restlessness, headaches. And then once again about the salmeterol has the increased risk of exacerbation of severe asthma symptoms if the patient is deteriorating. Please use cautiously if at all. Okay, so we just go into more of the drug interactions. DIG causes an increased risk of dysrhythmia, and that's because the albuterol and the DIG are fighting for that receptor site. Somebody's going to lose, and you're not going to have the drug. Beta-androgenic blocking agents, direct competition for beta sites, resulting in mutual inhibition of therapeutic effects. So that's your answer to that. This was a board question, by the way. So the bronchodilator of choice when a patient is on a beta blocker is I can't even speak today. Impregnine. And of course, those come with their own risks. And what's your trade name for that? Is stop. Okay, you have your beta agonist drug interactions. Once again, this is DIG. You have the increased risk of dysrhythmia, mostly because you have your beta. These are beta-androgenic blocking agents. So they're competing for those beta sites, and then there's mutually inhibition of therapeutic effects. So the bronchodilator of the choice when a patient is on any kind of beta blocker, such as propranolol is one, is this is the other name for Atrovent actually. Even if the patient is on beta blockers for eye drops, you should always prescribe Atrovent instead of albuterol. Clinical uses of bronchodilators, you can treat for COPD, asthma, bronchitis, pneumonias, all sorts of things now. This is just how we use them. Albuterol MDI dose, 2 puffs every 4 to 6 hours is how they're prescribed. Usually now, we like to give everyone a spacer. Spacers are usually not covered by the insurance, so you have to think twice about that. They're about $20. So, and also there's been a lot of literature stating that like nebulizer treatments and MDIs, when MDIs are used correctly, are just as effective. So don't worry too much about prescribing albuterol meds unless you really have somebody who's really severe. Exercise-induced bronchospasm. I wanted to talk to you a little bit about that also. This is nothing that's on the exam, but when you have somebody who comes in and says, I always wheeze when I'm exercising, can I have an albuterol inhaler for exercise? There's been a lot of research now stating that there's no such thing as exercise-induced asthma, which is exercise-induced bronchospasm, which is probably the correct word. It's actually the patient really does have asthma, and the exercise is the trigger. So they're actually, you would chart them, you would document them as a known asthmatic, and you would follow that chart. Um, you know, the guidelines for asthma, how many times are they using the inhaler, and start treating them. These are people that actually end up being treated with a daily inhaled corticosteroid. So don't ever discount the fact that this is really asthma that you're dealing with, and they think they just have exercise-induced asthma. So you always have the expert panels that we've learned that we have to follow. Those are the guidelines that A, they keep us on our toes, and it's evidence-based practice, and B, it also keeps us out of court. So they say that the short-acting beta agonist can be used in adults, all ages. Actually, all ages can use albuterol. It's a safe drug, even for infants. You even used it on NICU patients. So albuterol is a great drug. Atrovent, on the other hand, used to be used in all patients, but not so much in small children anymore. Albuterol is least expensive, although an albuterol inhaler without insurance is about $45. Patient education, you're always going to educate your patients on the correct way. And actually, the recommendations are to use a spacer with all patients, so you can deliver the exact dosage. Okay, so then we have xanthine derivatives. Theophylline, I'm not quite sure why it's on the exam, but it is. We don't really use theophylline anymore. So you'll see theophylline and caffeine. Caffeine is basically just used in the NICU nowadays, and it's for apnea of prematurity. You may run into that on a board question. We can get into that later. Theophylline, though, is for our exam here. Though there are a couple of theophylline questions, I do believe. So we'll make sure that you've got the correct information about that. So actually, we have, say you have somebody who comes in and they're overweight and they're a smoker and they're taking theophylline for their asthma, which, by the way, probably never happens anymore. And he's going to tell you that he's going on the Atkins diet. Okay, so you have to understand. Now you're getting the picture that there must be something involved with protein. If I'm asking you a question like this, protein binding. So he's asking his provider if he needs to worry about anything. He's on the theophylline, he's a smoker, he's heavy, he's going to lose some weight. Is there anything he has to worry about being on the theophylline with this diet? So here we're going to look here at how it's actually absorbed. And it's eliminated renally, no problem, right? We don't see any problem there. I don't see anything on this screen with pharmacokinetics, how the drug is working on the patient at all. All right, so then same thing here too. We were just worried about toxicity in that. So really, nothing's jumping out at us. I knew nothing of what I'm going to tell you until I actually started teaching this course. Because we don't really use theophylline anymore. But these are you need to worry about it for hypertension and coronary insufficiency and congestive heart failure. And of course for the toxicity, and we'll get into the signs and symptoms of toxicity. All right. So back to the question of the patient who wants to start the Atkins diet. All right. So what should we tell him? What should we tell this man? Should we say, oh yeah, sure, there's no worry at all? Should we schedule him for theophylline levels while he's on the diet? What should we do with this? The answer is, I believe that he needs to be, if he's on high protein, low carb diet, is actually a big problem with his theophylline. So let me go scroll down a few screens here. And of course it's probably not on here. Let's see. Yes, it is. So low carbohydrate, high protein diet increases the clearance of his theophylline. So therefore, he's not going to be getting much drug, right? If he's not on a higher carb diet, he's on no carb diet. So that would be why. So he's not at risk for toxicity at least though, but he's at risk for an asthma attack if that's his main drug he uses for control, which in this day and age, let's hope that he's not. So it's kind of I don't find it to be a useful question, but that's what I mean. There's some little things about all these drugs, especially older drugs, that we may not know about. So here, for testing purposes, if you have somebody who wants to go on to a high protein, low carb diet, and they're on theophylline, you need to make sure that they know that their drug is going to clear, right? It's going to clear quicker, right? Is that what I told you? It increases the clearance. Holy cow. It increases the clearance, which means he's not going to hang on to the drug in his bloodstream, all right? All right. So what are the signs and symptoms of theophylline toxicity? Theophylline toxicity is really a problem when they did use it, because by the time the patient's having symptoms, they're really, really sick. That's the problem. Okay, now let me scroll. Okay, so toxicity occurs when the level hits about 20 mics per ml. Okay, so you'll have CNS effects, or irritable, restless seizures, insomnia. Now, to be perfectly honest, sometimes when you start theophylline, that's how the kids and the adults act anyway. They have those things. They have heartburn, they have reflux, they'll have cardiac symptoms, palpitations, tachycardia, hypotension. They can have dysrhythmias. The toxicity occurs over 20, when your level is over 20. So they'll have nausea, vomiting, diarrhea, headache, insomnia, and irritability. Okay? So those are the things you need to know. So if somebody calls up and they're on theophylline, what are you going to do? Are you going to give them advice that, gosh, just schedule an appointment for 2 or 3 days? Or are you going to have them seen the same day and do a theophylline level? You're probably going to have them come right to your office, send them right for a stat lab. You're probably going to hold them also for that stat lab. You won't let them go from the hospital. And you're going to tell them not to take their dose until you know what that lab is. Any kind of drugs anymore that the patients are on that you have to do levels, I think are really problematic. I think you've all seen in clinical practice now what a nightmare Coumadin dosing can be. So you can just imagine when you have something like this that's an older drug and that requires a level, and even digoxin as well. Digoxin is touchy too, but this drug seemed to really be extremely touchy. So that is it about theophylline. So you know that the signs and symptoms of toxicity, you know what level it's toxic, and you know now what you're going to do if your patient calls and says that they are having a really big problem, nausea, vomiting, and you're going to bring them right into your office and you're going to send them for that stat lab. And that will keep you out of trouble. Caffeine, I've never seen caffeine used in an adult. These are all the things that it can cause. Insomnia, agitation, irritability, headache, nausea, vomiting. Yep, caffeine's really, really pricey, believe it or not. We always give it in the NICU. This is just not for anything other than your knowledge base. Caffeine is given for apnea prematurity. It works in the CNS where it stimulates the baby so the baby does not forget to breathe. That's all that it's used for. We usually stop the drug at 34 weeks, just corrected gestational age. Kids usually don't go home on caffeine. They go home on caffeine. They also have to go home on a monitor. And it actually is a helpful drug. We do not use, and theophylline was used prior to caffeine in the NICU years ago. So we do not use that anymore. Let's see. And I told you about the low carb, high protein, and drug interactions with caffeine. This drug interactions with the caffeine also goes for people who drink a lot of caffeine though too. So you might want to pay attention because you have a lot of patients who insist on doing all their energy drinks nowadays, and it's just not, it affects a lot of things, not just in their body, but with their drugs as well. And I'm trying, let's see, These are more theophylline and your doses that would you use. I've not seen a child on theophylline in a very, very long time. Here we went through your apnea prematurity. Once again, it's a drug that you have to load first. It's 20 milligrams for KIG, and then a maintenance dose. Usually we give a maintenance dose of 10 per KIG per day. Once again, we do not treat with theophylline, but so you won't ever run into that in any kind of a board question. Okay, the only problem with theophylline is it's really super cheap, I would believe. So people may want to use it for that reason, but I'm kind of highly doubting it. I'm so sorry, this is the whole PowerPoint full of the theophylline. But you need to know the signs and symptoms of toxicity is the main thing. Not much else. Patient education, if you do have somebody on theophylline, they need to also avoid a large amount of caffeine because they are working on the same receptor sites. Okay, so inhaled anticholinergics or Atrovent. Okay, your big treatment for COPD nowadays is Spiriva, or the Spiriva type inhalers. They have Atrovent in them. They are actually, it's probably one of the most popular drugs used. It is kind of pricey. There's been some problems with Medicare lately where other drugs are being replaced, but Spiriva is a good drug. That's the trade name, and the generic on your state on your F&P boards, and I believe on our tests as well. And if not, I can give you both names if they're not listed. They usually do have both names. You should try to learn both names. I usually can tell by looking at the drugs by both names, but do not ask me to say them half the time. I don't know what my problem is. I've always been this way. But anyway, this is Spiriva, and what you need to know about Spiriva is it's an inhaled anticholinergic, and it's used for the treatment of COPD. And once again, there's a bunch of charts that we need to follow the treatment of COPD and the steps. When it gets closer towards the end of the course, we'll talk, and maybe I'll even be able to post it, but there is definitely questions on the boards that go in that stepwise fashion, where they're drag and drop, where you need to put in order of progression. If you have somebody come in and you've given them Spiriva for COPD and now they're having other symptoms, what will you do next? And there's actually drag and drop boxes that were really pretty scary, but there is, once again, those guidelines, and those national guidelines keep us safe, and that's what we're being tested on. So you guys will be okay. Okay. Okay, so anticholinergics, precautions and contradictions. And of course, not for an acute bronchospasm. This is a maintenance drug. You wouldn't use it if you knew somebody had a problem with it. You're always going to look at your expert panel 3 guidelines. You can, Atrovent can be used in children, and I believe it's over 4. Okay, here's your patients will complain of being an anticholinergic, so just think about it. You know, you dry mouth, can't pee, urinary retention, constipation, all those same anticholinergic effects that you would have if you took an oral anticholinergic. Okay, for COPD, you probably need to know the dosing. You're going to take 2 puffs 4 times a day. There's a maximum on it that can also be used per nebulizer. You know, Spiriva, it has those single capsules that you break when you turn that little cartridge. So this is Atrovent, actually. Atrovent is 2 puffs for COPD, and then Spiriva is the 2 puffs of a single capsule that's broken inside that little device they have. I don't know if people have seen those. I'm sure you guys have. You can also take it for anticholinergics for asthma. Okay, and I don't think there's much else. extra clinical use and dosing. Free, that's very expensive, as you can see, $223 a month. The insurances are paying for less and less and less. They, this is exactly what's happening. You've got your combined albuterol atropine products. Symbicort is one, much cheaper than your Spreeva and your Advairs, and that is like what's on a new Medicare list. After January 1st, I was inundated in the office with faxes from pharmacies to please change X, Y, and Z drug to this unless you had uh, better rationale why you were giving it. So the drug companies who used to run everybody's practice, now Medicare and the insurance companies have kind of taken over with that, even with the medications. If there's not a generic for it, it's almost, people can't pay for their meds anymore. Okay, and I think that is it for this.